A very good morning, good afternoon, good evening to everybody. Thank you very much for joining our Obesity Cobweb webinar. My name is Dr. Gintara Valentelita, and I will be coordinating this morning's webinar coming to you from Ireland. So just a couple of minor housekeeping points. So we will be recording this webinar, and this will allow you and any of your colleagues to watch back our recording, which we will share the link to after a few days after this webinar is complete. So our webinar today focuses on optimizing obesity prevention, early interventions, socioeconomic factors, and prescription medications. And we have three speakers who will be presenting. We have two speakers from Australia, and we have one speaker coming to you from a global perspective. So if you have any questions as the presenters are presenting, please feel free to put in your comments or any questions in the Q&A or the chat functions, and we will answer all of these questions at the end of all three presentations. So I would like to introduce our first speaker, Dr. Anagha Killedar. She is going to present on the cost effectiveness of an early childhood sleep intervention to prevent obesity, looking at socioeconomic position. So Anagha is a research fellow, and she's also a health economist at the Leader Centre for Health Policy, Economics and Data at the University of Sydney. Anagha completed her PhD in 2021 at the University of Sydney, and her research focused on developing a model for conducting and applying equity informative economic evaluations of childhood obesity. So I welcome Anagha. Please feel free to take over. Thank you.
Thank you so much, Gintara. I'm just going to share my screen. I think everyone should be able to see that now, and I can't see anyone's faces, so if there's any issues, please just shout out. So thank you so much for the opportunity to speak to you all today. So as Gintara mentioned, my name's Anagha. I work at the University of Sydney, and I'll be presenting one of the studies from my PhD. And the titles on the page there is the cost effectiveness of an early childhood sleep intervention to prevent obesity affected by socioeconomic position. I just want to acknowledge the co-authors on this study, including Alison Hayes and Thomas Lung, who are my two PhD supervisors, and the early prevention of obesity in childhood research collaboration. And so this is a collaboration led by Professor Louise Bauer, and I did my PhD within this group. And they're really focused on obesity prevention within those early childhood years, so that 0 to 5 year age group. So just to give you a background of the Australian context, these are slightly old statistics, but they, I think, still give you a bit of an understanding of the context in Australia. So about a quarter of children have overweight or obesity, and there's also these clear socioeconomic inequalities in these rates. So this is a figure from the Australian Institute of Health and Welfare, and you can see here that children who live in lower socioeconomic areas have much higher rates of overweight and obesity compared to those in the highest SES areas. There's been a huge range of interventions that have been trialled over the years, but no clear silver bullet type of intervention in this age group. And so this is where economic evaluation can be quite informative for decision makers by demonstrating the balance between costs and benefits of the different types of options available. Targeted approaches where interventions are delivered to population groups that are particularly at need, for example, those in low socioeconomic areas, could be a way to address inequalities, but only if the effectiveness and cost effectiveness is maintained within that target group. So with that in mind, the aim of this particular study was to determine if the cost effectiveness of an infant sleep intervention differed across different socioeconomic groups. So the intervention that we're looking at, that sleep intervention, was trialled within the Prevention of Overweight in Infancy trial, which was conducted in New Zealand and described in these two references at the top here. And this was a 4-arm trial, which recruited women who were in the later stages of their pregnancy, and the interventions were started antenatally and continued up until the child was 2 years of age. In the usual care or standard, in the usual care arm of the trial, the families received standard well-child services that are offered to all families with infants in New Zealand. And this involves free home and clinic visits, providing general infant health advice. And then in addition to those standard well-child services, those in the sleep intervention group received guidance around healthy infant sleep behaviours. And this involved one group session and one home visits as a standard for everyone within this group. And then there was also this optional component, which had 4 different levels of intensity. So you could decide, or families could decide which one of these they wanted, or they could decide that they were happy with the standard part of the intervention and leave it at that. Then there was the food, activity and breastfeeding intervention, which was a much more intensive intervention, involved 8 contacts with families as a standard for everyone in that group. And this was a mix of home visits and GP sessions. And then the final arm of the trial combined both the sleep and the FAB intervention. So in a previous economic evaluation of this trial, only the sleep intervention was found to be cost effective, and that economic evaluation is published in that last reference here. And so because that sleep intervention was found to be because only the sleep intervention was found to be cost effective at a whole of population level, for this particular study, I just focused on the sleep intervention compared to usual care, and examined whether the cost effectiveness differed or changed across different socioeconomic groups. So now I'm just going to give you a rough overview of the methods, and then I'll go through those in a bit more detail. It might get a little bit technical, but I'll try and keep it as simple as I can. So we started with deriving SEP. So just whenever I say SEP here, I just mean socioeconomic position. So we derived SEP-specific intervention effects and intervention costs from the trial intervention. So the original trial data had follow-up results from up until the children were aged 5. So we used those age 5 results in our study to determine the SEP-specific effects and costs. We then applied it to a nationally representative cohort of Australian children, which was then those age 5 children in those cohorts were then used to model out BMI up until age 17 using a model that we developed. So that model allowed BMI at every year up until age 17 to be simulated at an individual level, which was then converted to weight status. So we converted that to healthy weight and overweight and obesity. which was then used to predict quality-adjusted life years, which is a measure that combines quality of life and length of life, and we used it also to estimate healthcare costs. So this simulation process, which was done at an individual level, then allowed us to separate the results into low, middle, and high socioeconomic groups, and then calculate what we call an incremental cost effectiveness ratio, which is a measure that allows us to work out what the overall cost effectiveness of an intervention is. So for those of you who are health economists, we used an Australian health funder perspective. The costs were valued in 2018 Australian dollars, and we used a 5% discounting rate for both costs and benefits. So just to go through that now a little slower. So we started with deriving those SEP-specific intervention costs, and we used the same methodology that was used in the original economic evaluation, but because we wanted to work out what those costs would be by socioeconomic position, we separated this out. So in the end, here we identified that the intervention had a higher mean cost in the middle and low SEP groups than it did in the high SEP groups. And the main reason for that was the differences in uptake of that optional component of the intervention. Yeah, you don't really need to look at the detail here. It's just that's the main message here, that there are different costs across the three groups. Then we worked out the effect size of the intervention by SEP group in a very similar way. Again, just using the trial data. And the main takeaway from this is that the effects of the intervention varied slightly across our three SEP groups, but we did have quite wide confidence intervals, because once we broke down the trial results into the three groups, we ended up with fairly small sample sizes. Okay, then we applied the intervention effects intervention effects and costs to a nationally representative cohort of Australian children. So this was using data from a different large cohort study of about 5,000 children starting at age 5. And so this process resulted in us having three cohorts three intervention cohorts for each of our SEP groups, and three control cohorts. So then each of those cohorts were then used for our modelling. So since many of the benefits of obesity at such a young age are likely to come to fruition over time, we decided that modelling these outcomes in our three intervention and control cohorts into the future was the best way to capture these longer-term outcomes. So we developed a microsimulation model. So that just means that we're modelling each of our outcomes at an individual level. And this model predicted BMI in annual cycles by socioeconomic positions up until age 17. So in this graph, this graph is just showing how the simulation works. And you can see that at a lower SEP in red here, there's a faster BMI trajectory being predicted than with higher SEP. And this matches quite well with the data from the observational study that we compared this to. Okay, so at this point, we've simulated individual level BMI up until age 17. And so this was then converted into weight status groups, so healthy weight and overweight and obesity using WHO growth standards, which was then used to predict out what we call utilities. And so utilities are a measure of health-related quality of life that are required in order to be able to conduct a specific type of cost-effectiveness analysis, which we call a cost-utility analysis. So these particular utilities were derived or taken from this study, which is a systematic review, which identified utility values for children with healthy weight and overweight and obesity. And these values were found to be lower in higher weight status groups, although this was a small but still statistically significant difference. So using those values, we were able to assign utility values for our weight groups and therefore be able to eventually calculate our quality adjusted life years. We used sorry, the animation's gone a bit wild there, but we used a similar process to estimate healthcare costs, where we used the healthy weight and overweight and obesity categories to then estimate annual healthcare costs. But you can see here that the healthcare costs that we applied were different by different age groups. And these numbers were derived from a top-down approach, which used national statistics on healthcare expenditure, on National Health Service surveys, and published data on relative differences in healthcare costs. Okay, so at this point, we've now got individual level simulated data on BMI, on weight status, quality adjusted life years, and healthcare costs, and our intervention costs right from the start. So this is all the information we needed to then be able to calculate our incremental cost effectiveness ratios. And so this is just a bit of a busy slide, but I will take you through it one by one. So we have our incremental healthcare costs. So this is essentially just calculating the healthcare costs that were identified in our simulated results in the intervention group compared to our control group. So it's a difference in those healthcare costs between intervention and control. And this was calculated across our 3 SEP groups. The negative sign just means that we're actually generating healthcare savings here. So those healthcare savings were greater in those middle and low SEP groups than the high SEP. And then if you remember from earlier, the actual intervention costs were higher in the middle and low SEP group. So that meant once we combined those intervention costs with healthcare savings, they sort of ended up offsetting each other, and we ended up with quite similar overall costs across our 3 SEP groups. And then our incremental BMI. So again, this is the difference in mean BMI between the intervention and control groups. Those differences ended up being higher in the middle and low SEP groups than the high SEP group. And just as a reminder here, these are the simulated results. So it means that these are the results we found at the end of our modelling period. That same pattern was identified in our incremental quality adjusted life years. So there was a greater effect size in those low and middle groups than the high SEP group, which brings us to our incremental cost effectiveness ratio. So these 2 results are sort of the headline results for any economic evaluation, where it's the ratio between the incremental costs, which are here, and the incremental outcomes, which are here. So our incremental cost effectiveness ratio here showed us that the intervention was more cost effective in these low and middle SEP groups than it was in the high SEP group. And then when we're looking at the quality adjusted life years as our denominator in that same sort of calculation, we found a similar result. So the intervention was found to be more cost effective in those low and middle SEP groups than our high SEP group. We also conducted some uncertainty analysis, which I might not go into too much detail, but the main message here is probably these percentages at the bottom, which show us that if we were to use a threshold, a $50,000 per QALY gained threshold for cost effectiveness, which is one that's sort of commonly used or commonly spoken about in Australia, but it is not an explicit one that's used directly in decision making. If we used that threshold, then the probability for cost effectiveness in the low SEP group was 92%. It was closer to, it was almost 100% in the middle SEP group, and then 79% in the high SEP group. Sorry. Done that. And then we also conducted a range of one-way sensitivity analysis. So this is just where we changed some of the parameters in our modeling that we weren't too sure about and retested the impact on the incremental cost effectiveness ratios. So the main takeaway from that is that the uncertainty in the utilities had the greatest impact on our results. But even with that uncertainty, that general trend of the differences across our different SEP groups still remained the same. So in conclusion, the sleep intervention had a moderate to high probability of cost effectiveness in all SEP groups. The cost effectiveness is greater in the low and middle SEP groups than they were in the high SEP group. And the takeaway or the main implication of this is that if we were to target the sleep intervention to low socioeconomic groups, which could be considered an equity promoting choice, we wouldn't have to make any trade-offs between equity and cost effectiveness. That's the paper for this study, in case anyone wants to read about it a bit further. And I'd just like to acknowledge my PhD supervisors again and my funding sources for the study. And that's everything.
Excellent. Thank you very much, Anagha. That was a really, really interesting presentation. And just to remind our audience, anybody who has any questions or comments on Anagha's presentation, please feel free to add these to the Q&A or the chat function. Thank you. So without further ado, we'll move on to our second speaker. Our second speaker is Dr. Joe Carrello. Joe is a postdoctoral research fellow with the Health Economics Unit at the University of Melbourne in Australia. His work mainly involves undertaking evaluations of new health technologies for consideration under and by the government subsidy. Joe was awarded his PhD from the University of Sydney in 2023, and his PhD thesis focused on developing and applying a health economic model for overweight and obesity in Australian adolescents. So with all of that in mind, Joe will present on the economic modelling of overweight and obesity in Australian adolescents. So over to you, Joe.
Thanks, Gintari. Excuse me. Now I'm just going to share my screen. Sorry. Just seeing if everyone can see my screen okay.
Not yet, Joe.
Oh, sorry. Hopefully that's all good now.
It is. Thanks, Joe.
Fantastic. Thank you. Yeah, thanks everyone for having me this morning, your time, and for the nice introduction, Gintari. Yeah, so as Gintari mentioned, I'm currently at the University of Melbourne, although I am presenting work I did in my PhD at the University of Sydney. I actually worked in the same research group as Anagha, so you may see some similarities in our modelling approach. And I'd just like to acknowledge my supervisors, Professor Alison Hayes, Associate Professor Tom Leung, and Professor Louise Bao, that contributed to this project, and specifically to Alison and Tom, who have done a lot of work in the modelling, in developing the modelling. So as Anagha mentioned, in Australia, like in many countries, overweight and obesity is a major public health issue and currently affects 1 in 4 young people. This is a concern not only because of the immediate impacts on their physical and psychological health, but also because excess weight tends to persist into adulthood, increasing the risk of developing chronic diseases in later life. If the prevalence remains at its current levels, this will translate to a considerable health and economic burden to society in the future. Not sure what it's like in Ireland, but in Australia, our government loves to make plans for these kind of things, but action tends to lag behind that. But, kudos to the government. They've developed a national obesity strategy, acknowledging the severity of this problem and developing a 10-year framework for action to reduce the prevalence of overweight and obesity through both prevention and treatment. So a primary aim of this strategy is to reduce the individual health and national economic costs due to overweight and obesity. And this is partly to be achieved through a very aspirational goal of reducing overweight and obesity prevalence in children and adolescents by at least 5% by 2030. The strategy also recognises that there are important opportunities for prevention across the life course, and in particular, the first 1,000 days. So that's consistent with what Anagha presented. And then also another key period, a key transitional stage of life is adolescence and early adulthood, where a lot of our lifelong habits are starting to form. So are we on track with the National Obesity Strategy? Unfortunately not. The size of the problem isn't really reflected in how government healthcare expenditure is in Australia. We spend less than 2% on prevention, and many children and adolescents with obesity lack access to appropriate weight management services. Part of the issue for childhood obesity is that while the costs of interventions are incurred up front, the benefits will not be fully realised until many years in the future. And in the face of competing demands for scarce resources within short-term political cycles, decision makers may favour investment in other patient populations with more immediate needs. So in other words, we're just kicking the can down the road. We prefer to treat chronic disease rather to invest up front and prevent chronic disease from occurring. Another reason it's really tricky, as some of you might know, to really engage adolescents with their health and health behaviour. But digital health, there's a lot of attention on it, and it's often promoted as a low-cost, scalable, and very acceptable to the adolescent demographic. However, it's unknown whether such strategies are cost-effective, or in other words, whether they represent value for money. So such information is essential to justify government expenditure on healthcare. In Australia, we have legislative bodies that inform government decision-making for pharmaceuticals and medical services, similar to NICE in the UK. Whether or not digital health would fall within the realm of government expenditure is probably another topic for discussion. But certainly, if government was looking at this as a potential tool to help improve the childhood obesity crisis, it would need that information that not only do these interventions, are they safe, do they work, but also do they represent value for money? So what we did is we didn't have any clinical trial data to work with. So we actually did a model economic evaluation of a hypothetical digital health intervention for the adolescent demographic. So we used a discrete time micro-simulation model for overweight and obesity in Australian children and adolescents, which is called the Early Prevention of Obesity in Childhood, or EPOC life course model, and that's the model I helped develop during my PhD. And we use an input population, a study population, a cohort of almost 1,000 14 and 15-year-olds in Australia, with overweight or obesity. And this was sourced from a longitudinal study, the longitudinal study of Australian children. And through survey weighting techniques, this study is representative of the national population of adolescents at that age. So the intervention, to design the intervention, we sought data from systematic reviews and meta-analysis. So to determine the effect size of the digital health intervention, we used the subgroup meta-analysis from a systematic review of 5 studies with participants aged 12 to 17 years. And to work out the cost of this intervention, we used the average cost from 26 digital health interventions that were costed in a systematic review. And most of those were costed using trial records. So we wanted to compare this hypothetical digital health intervention using those effects and costs sourced from the literature and compared it to no intervention or business as usual. So just keeping things the way they are right now. For those health economists out there, the perspective was a healthcare funder. So that just means that we were only considering costs of the healthcare system. We weren't considering things like productivity losses or premature mortality in our modelling. The time horizon, so how long we modelled the costs and effects for was over a lifetime. So we simulated this population of 14 to 15-year-olds over their lifetime. So that's until they reach death or 100 years of age. We also applied a discount rate of 5%, applied to costs and qualities, and we also explored uncertainty as well. So this is just an overview of what we did with the modelling. So the model input, we simulated 2 cohorts. So we had our control cohort, which was that study population of 14, 15-year-olds with overweight and obesity. And then we had an intervention cohort. So that's the same cohort of 14, 15-year-olds, except we applied the reduction in BMI and the intervention costs at baseline. And that was our mean intervention effect size and the confidence intervals there, and that was our mean costs and the confidence intervals there. So we simulated both those cohorts through the model, and then at the other end, so until all these children had reached death for 100 years, we then summarized the output from the model, and so we were able to get their life course BMI trajectory. So that's for each individual in the model, we could see what their BMI was like over their lifetime. And then also the weight status and how that changed over their lifetime. And then we also summed how much healthcare costs they accumulated over their lifetime and also their quality adjusted life years or quality. So that's how long did they survive for and what was the quality of life of those years. Just to further visualize this intervention, I'll just put this graph up here. So this is our control cohort, and this is our BMI distribution. So that cohort of about 1,000 children, if we plotted each of their individual BMIs, we get that kind of curve there. So most around that low 20s, so healthy weight. And then if we applied the intervention effects to our intervention cohort, we see how that BMI distribution would shift to the left. So we applied that intervention effect size, the reduction in BMI, to all children in this cohort, so it shifts that way. So they had a loss in weight at baseline, and they also incurred the costs of that intervention. So this diagram here, so this is an illustration of what the model does, and this represents 1 year. So if you think about it, this is 1 year. So we had our input population come in, the control cohort or the intervention cohort, and then each individual, or those 1,000 children, each one of them had a change in their BMI over the following year. And that's calculated based on equations, based on their age, sex, and their current BMI at the start of that cycle. And we've developed those equations using that same study, the longitudinal study of Australian children, for children and adolescents between 4 to 19 years, and through National Health Survey data between 95 and 2012 for adults 20 years and older. So just to illustrate here, this is just some validation of our BMI equation. So those point estimates are what we actually observed from the longitudinal study of Australian children. So that was actually measured data of what the BMI, the proportion of children with healthy weight, overweight, and obesity. And then the shaded lines are our modeled simulations. So you can see it's quite accurate there in estimating the proportion of and the BMI trajectories for these children. So once children come into the model and they, over a year, they have a change in their BMI, then we assign them a weight status. And so we use the World Health Organization's BMI age and sex cut points for children and adolescents 4 to 19 years. And then once they hit 20 years and older, we use the World Health Organization BMI cut points. So that includes underweight or healthy weight. We merge those together. And then overweight, and then the different classes of obesity. And that's a strength of our modelling approach, that we can capture those higher classes of obesity where costs and health outcomes are poorer. Once a weight status is assigned, all individuals are exposed to annual all-cause mortality risk, and that's based on age, sex, and weight status. So we use Australian life table data, and from age 35 years onwards, there's differential mortality hazard ratios for each 5-point increase in BMI. So just visualizing that. So this is for a cohort of individuals starting at 20 years of age, and you can see if you start at healthy weight, your your trajectory, your lifetime trajectory, survival trajectory is much longer than if you started at severe obesity. So that's just showing the proportion of each cohort by their starting weight status. So once individuals are exposed at mortality risk, they're either alive or dead in each year. And for those alive, they incur annual healthcare costs. And the way we assign healthcare costs, we used national disease expenditure data, which includes things like pharmaceuticals, hospital costs, outpatient costs as well. And we apply excess costs for those with overweight and obesity classes relative to healthy weight. So you can see here, as we would expect, as we get older, our healthcare costs increased. But also there's that differential effect of the different weight status classes at each age bracket. And then we also assigned utility or quality of life, as Anagha explained earlier. Utility is a measure of health-related quality of life. It's on a scale of 0 to 1, 0 being death, 1 being full health. And as we can see, these utility values that we assign to each individual in the model based on their weight status, these have been informed by systematic review and meta-analyses. So we see as individuals get older, their quality of life declines, but then there's also that differential effect in both adolescents and in adults by weight status as well. So our results. So this is what we call a cost effectiveness plane. So what we did is that we simulated those two cohorts, the control cohort and the intervention cohort, and then we compared their total costs and health outcomes. So on the x-axis here, this is the difference in health outcomes or qualities between the intervention, the digital health intervention, and the control, so no intervention. So we can, and then on the y-axis here, these are the incremental costs. So this is the difference in cost between that intervention cohort and the control cohort. So when we compare those two cohorts after they've been simulated over their lifetime, we find that in the base case, this intervention, this hypothetical digital health intervention, was both cost saving and it improved population health outcomes. So that's really positive. That's what decision makers like to see for any healthcare intervention. But like I said, we also explored uncertainty around this estimate. So we had, remember that those confidence intervals around our costs and our effect size. And we find that cost wasn't, our estimate wasn't as sensitive to cost, but it was a lot more sensitive to the intervention effect size. So our confidence intervals for the intervention effect size from the digital health intervention were much wider. So they really impact the uncertainty around our estimate of how cost effective this digital health intervention was. And then we plotted this on what we call a scatter plot. So again, the axes are the same. This is your costs on the y-axis. These are your health outcomes. So we do non-parametric bootstrapping, which, to try and simplify what that means, is that we resample our base case thousands of times, and then we get a range of figures around our point estimate. So we see in the base case, predominantly that's still in this southeast quadrant, which is what you want to see, because this is where it's cost saving and improves outcomes. But then if we use the lower cost side, that wasn't much of a change, same as the higher cost. But we see, there's a lot more uncertainty there around this treatment effect size that we've sourced from the literature. And then we use that to model a cost effectiveness acceptability curve. So as Anagha mentioned, this is our ISA. So that's our difference between costs and health outcomes between our intervention and our control. And these are the range of values of an ISA at the bottom. And as Anagha mentioned, in Australia, we don't have an explicit cost effectiveness threshold. I know in the UK you do. NICE has a threshold of £20,000 to £30,000 per quality gained. We have an unofficial threshold of around $50,000 per quality gained. But we can see in the base case and in the low and high cost scenarios, there's still a very high probability of it being cost effectiveness below this threshold here of $50,000 per quality. However, there's a lot more, again, this effect size. If we were to use that low effect size from the literature of the digital health intervention, the probability of cost effectiveness, it's about a 60% probability it's going to be cost effective at that willingness to pay of $50,000 per quality. So just to summarize, this study showed that digital health interventions for adolescents with overweight and obesity demonstrate really good potential as cost-effective solutions to address this growing public health issue, but recognising that results are very sensitive to that intervention effect size. So I think we do need further research of digital health interventions effectiveness in adolescents. And just a quick summary of strengths and limitations. So certainly a strength is our microsimulation modelling approach, which really captures that heterogeneity within the simulated population. We also account for costs and outcomes over the life course. So as you can see, if we just measure interventions during early childhood or adolescence, quite often they're not cost effective. But if we then model them and we model how that will affect their life, the children's lifetime trajectories in terms of their weight status, quite often they're very cost effective. However, that is associated with its own uncertainties, and it's really based on the assumptions you put in the modeling. Our modeling approach is really good as well because we're able to capture those classes of obesity where costs are often greater and health outcomes poorer than obesity, just measuring obesity alone. Also some limitations, we didn't model weight regain. So, there's lots of evidence out there that suggests that, individuals after losing weight put it back on over the following years. We've assumed that as a result of the intervention, it alters the individual's BMI trajectory for the rest of their life, that they don't shift back to that original trajectory they were on. The modelling also doesn't account for the present unobserved factors influencing development of overweight obesity, such as ethnicity and socioeconomic position. So Anagha's done some really good work in developing the modelling for socioeconomic position for childhood and adolescents, but we'd, I guess, like to do that for adults as well in the future. And this would allow us to do things like distributional cost effectiveness analyses. So our results just report on population health. Being able to do a distributional cost effectiveness analyses will also tell us whether these interventions would increase or reduce health inequalities. And that's it there. So just like to acknowledge the Australian Prevention Partnership Centre that funded my PhD. And I just got a link to the paper there. I'll stop sharing.
Thank you very much, Joe. That was a very excellent overview, and I look forward to opening up our discussion, and I'm sure the audience might be full of questions at the end. So this is just a gentle reminder for anybody who has any questions or comments for any of the presenters, please put them into the Q&A or the chat functions. And finally, we'll move on to our third and final presenter for today's Obesity Cobweb webinar. We have Sarah Rickwood. Sarah has 30 years experience as a consultant to the pharmaceutical industry, having worked in Accenture's pharmaceutical strategy practice before she joined IQVIA. She has an extremely wide experience of international pharmaceutical industry issues, having worked most of the world's leading pharmaceutical companies on issues in the US, Europe, Japan, and leading emerging markets. She is now Vice President at the European Thought Leadership in IQVIA, a team that she has been running for the past 13 years. And today, Sarah will present on the obesity revolution, why the advent of new obesity prescription medications represents unprecedented opportunity and impact for healthcare systems. So over to you, Sarah.
Thank you very much, Gandari, and hopefully everybody can see my slides. So yes, I am going to talk about the new pharmacotherapies that are coming into the market, but I want to emphasize that the interventions that we've talked about in the previous speakers' presentations, so non-pharmacological interventions, are also extremely important. The issue is that we now have a new set of tools, which are new anti-obesity medications. They do have huge potential. They also are at the moment expensive. And it is a very live question how these actually get used by healthcare systems and individuals in order to manage obesity. And that's a discussion that we are going to be having for the next decade and beyond. If we just rehearse, as the other speakers have, why this is so important, I'm going to take a global view here. It's actually from the World Obesity Atlas, and it's looking at the percentage of people with obesity defined as BMI over 30 on the x-axis, and the GNI per capita, the wealth of countries on the y-axis, it's the percentage of people with obesity, and on the x-axis, it's the wealth of countries defined as GNI per capita. The bubble size is the absolute numbers forecasted of people with obesity in each country by 2035. So one of the key issues that we should remember when we look globally is obesity is not and will not be just a rich world problem. In fact, the World Obesity Federation calculates that the majority of the world's obese adult population, that's BMI 30 plus, will actually be living in lower and middle income countries by 2035, even with the use of anti-obesity medications. That is undoubtedly going to be the case because the rise in obese people far exceeds the penetration of the anti-obesity medications. And this matters because, of course, obesity causes significant morbidity and mortality afterwards in cardiovascular disease, diabetes, kidney disease, and other areas. And these lower and middle income countries are much less well prepared to address those expensive consequences of obesity. So this is truly a global challenge. Of course, public health interventions and individual programs on weight management and prevention of obesity have been developed for many years, and alongside those there have been pharmacotherapies. What is different now is the level of effectiveness of those pharmacotherapies, and also how many of them are being developed. I'm sure that all of you are aware of the GLP-1s and the GLP-1 GIPs, so that's semaglutide from Novo Nordisk, as Wegovy when it's an obesity agent, and tirzepatide from Eli Lilly. And there's also the older obesity agent liraglutide, but those are actually only the start of what is potentially a large number of new types of agents that could be developed by the pharmaceutical industry and come to the market. Not all of the 149 assets I've got here, ranging from discovery to marketed, will be approved and will come into countries. But the fact of the matter is there is much, much more to new obesity treatments than the GLP-1s. In fact, there's over 50 different mechanisms of action in development at the moment, and there's more than 70 companies worldwide, both the largest companies in the world, but also a lot of small startups behind the development of those agents. And they're spread, these companies, across the US, Europe, but also actually from China and other markets. So it is likely in the next decade that healthcare systems will have a broad range of choice as far as approaches to obesity are concerned. And the other thing that will be happening in this time is further trials that look at the outcomes of use of anti-obesity medication in comorbidities associated with overweight and obesity. So here are three molecules. Two of them we've already mentioned because they're in the market, semaglutide and tirzepatide, and then survodutide is a similar type of molecule that's not yet approved but is likely to be approved in the US first around 2026, 2027. And we're looking at the cardiovascular metabolic outcomes late stage trials that the companies behind those agents have. One of them, Select, for semaglutide, of course, read out in 2023. And that was looking at 17,000 people with obesity, following them over a 4-year period, and looking at major all-cause cardiovascular events and demonstrating a 20% relative rate risk reduction. In the details of that trial, there are some differences. Not everything was statistically significant, but the fact of the matter is it was the first trial which demonstrated that these agents are not simply reducing weight, they are also reducing risk of serious events associated with obesity. And the intriguing thing for that semaglutide trial was that it was showing cardiovascular risk reduction before there was significant weight loss, which suggests it might be an independent mechanism, although more work needs to be done. But it's not just CV outcomes that we are seeing trials in. The pivotal trials on obesity in terms of metabolic outcomes for both semaglutide and tirzepatide have shown significant reductions in the risk of progression from pre-diabetic states to diabetic states. In the case of tirzepatide, when they were looking at overweight people who were pre-diabetic, it was a 94% reduced risk of progression to diabetes. That obviously matters because diabetes is both extremely problematic for the patients who have it in terms of their medicalization, as well as causing significant and distressing sequelae. Beyond that, heart failure, chronic kidney disease, obstructive sleep apnea, and also NASH/MASH, so that's fatty liver disease. All of these comorbidities, or CV-MET comorbidities, are seeing outcomes trials. And outside of the CV-MET space next year, there will be the readout of 2 trials for semaglutide on the neuroprotective effects of the agent in early Alzheimer's disease, which may lead to an addition to that product's label in 2025. In short, it's not only the number of agents that are in the pipeline and the range of mechanisms of action, but also the fact that there is significant investment in trials that are looking into the broader benefits of these agents in weight-associated conditions. This means that we expect that the market for obesity agents is going to be extremely complex going forward. Firstly, there's actually two markets. The out-of-pocket obesity markets, that is prescribed medications. We're talking about people who have legitimate weight issues and receive a prescription medications. But the out-of-pocket market in many European countries has gone far ahead of the reimbursed obesity market. In the US, it's a more mixed picture because in the US, we do see Medicare cover, for example, semaglutide for patients who are obese with a cardiovascular risk factor. So there are two markets, out-of-pocket payments and the potential for the reimbursed market with obvious health equity questions related to that. It is likely in the future that there will be a market for medications that promote initial weight loss, induction, in other words, but also the need, quite probably, to continue to use agents for maintenance of that weight loss. As I mentioned previously, people who lose weight tend to regain weight, and it's been seen in the trials that if you discontinue agents, you will regain weight. So this is a very live debate, how long you need to use these agents, and there is no definitive decision, but it is possible that we will see there is a need to use a maintenance type of agent longer term. And within those two, there will probably be, in the end, when there are a larger number of agents on the market, differentiation by BMI, how severely obese an individual is, the type of comorbidities they have, because if you saw with the outcomes trials, not all agents are going to be demonstrating outcomes in all comorbidities, and other phenotypes as well, because ethnicity and gender may also be important. And in the end, it will be about understanding the real world data that will be critical here. So there is huge potential for the anti-obesity medications, but we must remember that probably globally only 1% of all the people who have obesity actually have had the opportunity to have access to these agents at the moment. So most of the story of the use of the anti-obesity medications is in the future. And to introduce them successfully, there's probably five elements that need to be addressed. It's about understanding the market and attitudes now, healthcare system readiness to actually have care pathways where these products can be used effectively. As I mentioned, at the moment, the majority of the market in Europe is actually a private out-of-pocket market. But payers, of course, have to take on the budgeting for these agents. Understandably, they're nervous given the number of patients that we are talking about, and they need to understand the outcomes and budget impact and cost benefits of these agents better. Healthcare professionals, because there are a broad range of healthcare professionals that could be engaged on obesity, need to understand their role, and patients, because this is chronic and a lifelong condition, absolutely have to be engaged in order to have successful weight loss and maintain it. So let's talk about each of those areas. So IQVIA has done a lot of research with patients, both broadly using our patient data, but also through depth interviews. And recently we did very detailed interviews with people living with obesity, either grade 1 or 2, in the US, Spain, and UK, to understand their experience of engaging with the healthcare system and the challenges that they believe they faced in managing their condition. These are recent interviews. So, of course, do bear in mind that semaglutide was approved for obesity in 2021, tirzepatide in 2023. We've had several years of experience of these agents, even if they're not covered by healthcare system. But patients still feel that they aren't taken seriously by healthcare professionals. Primary care physicians, who are often the gatekeepers for referrals, provide only general weight loss advice. There is a considerable amount of change that needs to happen in healthcare systems to provide the kind of structure in which patients could access weight loss medications effectively. But it will not only be about weight loss medications. Mental health, as we've talked about earlier in this session, is a key issue for patients with overweight and needs to be addressed alongside managing the weight loss medications or other approaches to weight loss. And in fact, patients are viewing the AOMs with a certain amount of reluctance and scrutiny. This is something that patients need to understand more about and be reassured on before they're going to embrace the use of these medications more broadly. So that's the patient side. We've also done research with healthcare professionals. This is from primary research we did in November of this year, so a month ago, in the UK, asking first about their awareness of different types of obesity medication. I might add the UK is the most advanced European country in terms of the use of obesity medications, both in terms of the absolute number of patients who are paying for obesity medications privately, so they are getting these prescribed by a doctor. That's about 500,000 patients at the moment, and that the healthcare system does cover Wegovy and is proposing to cover Mounjaro in the very near future. And the doctors we interviewed here were doctors who said they were treating at least 100 patients with obesity a month as well. Nevertheless, what the GPs report when they're asked for top-of-mind awareness of obesity medications is not the latest medications, so semaglutide, tirzepatide, or their brand names. It's actually still orlistat, which is a much older and much less effective medications. The cardiologists are aware of Ozempic, probably because of that SELECT trial that I mentioned, because they have seen the cardiovascular benefits of use of these agents. So I'm going to talk from a European perspective here, with a little nod towards the US as well. The situation with respect to public reimbursement of these new obesity agents is very much at the start of the journey in Europe at the moment. If I just go down to the bottom left first, in the US, Medicare, which is the drug reimbursement program for the over 65s, is covering Wegovy, that's semaglutide, for obese patients with heart risk. And the Biden administration just last week proposed broadening that coverage to the whole of Medicare. But of course, it won't in the end be the Biden administration's decision. The question is, will it be followed through by the Trump administration? So the US is addressing this issue at scale and leads globally. In Europe, the UK leads, although reimbursement is restricted with proposed coverage for both Wegovy and Mounjaro. There's some very limited reimbursement in France, and we don't have any in Germany, Spain, and Italy at the moment. And Germany has one of the issues that actually Medicare has right now, which is actually it is not possible by law for it to have state coverage of obesity medications. In many cases, this is a legacy of an era when obesity medications were not effective, and it was quite sensible to say public funds should not go to weight loss agents that don't work. But now, of course, we do have effective medications, and we saw in October the announcement of an ambitious program in the UK that would provide tirzepatide, that's Mounjaro, to, reports vary, but between 22,000 and 250,000 patients in England over the next 3 years. And they're going to start with the most obese and sickest patients first. Obviously, that is completely logical to do, and combine it with a real world study, which will be in Manchester, which will follow broadly the impact and outcomes of the use of Mounjaro in that respect. So this is very interesting. It is possible that this approach will be followed by other European countries, certainly watched closely by health technology assessors. However, there are actually probably more than 13 million adults in the United Kingdom who are overweight and obese. So you can see that actually the percentage that will get access to obesity medications in the next 3 years in terms of NHS coverage will be a small percentage. It will be less than the share of patients who are covering obesity medications through their own funds, and health equity challenges remain. Weight loss agents, the new anti-obesity medications, they are on patent. They are relatively expensive, but in fact, price competition is going to come quite soon. Semaglutide moves off patent in certain countries from 2026. China is one of those countries. Canada is another. It won't happen in Europe at that point. As new agents come in, it's likely that there will be price competition. There are going to be small molecule oral agents coming in. They have a different cost of goods proposition, and we already see price competition in the private market, and that's something that needs to be factored in to perspectives on cost effectiveness. In the longer term, real-world evidence is going to be a critical factor here. Firstly, on the left-hand side, this is a US study. It's important to use real-world evidence to understand impact by BMI level. As BMI rises, the number of comorbidities these patients have grows very, very rapidly. It's very rare for somebody to have a BMI of 40, which is morbidly obese, and have no comorbidities. That is why the UK is focusing on the BMI over 40 patients first. Another issue, right-hand side, this is actual trial data, and it's the active arm for one of the medications on the market at the moment, is that patients respond very differently to weight loss agents. This is the treated patient universe. Some patients had spectacular levels of weight loss, others actually gained weight on the trial. Overall, that was a far smaller number than lost weight. As you can see, the average level of weight loss was significant, but increasingly it's going to be important to try and understand if you can predict which patients will respond well to these agents and which patients actually don't see much of a response for them. It would be a waste of time and money to treat. And the last point I'll make is persistency. This is why it's so important to make sure that patients are engaged, not just in terms of taking a medicine, but in a holistic interventional program. Here's recent Canadian data. It's on older agents. So Ozempic is the brand name for semaglutide when it's a diabetes agent, and Contrave, Saxenda, and Xenical are older agents. But what it is saying is that in Canada, in the private market, patients do not see strong persistence out to a year on medication. In fact, generally, at best, over a third of patients remain on these agents a year out, which means that they are probably not seeing long-term benefit on these agents. Whether this will also be seen with the newer agents, because bear in mind, we haven't got this data for the newer agents at the moment, remains to be seen. But if the true benefits of weight loss are to be realised, we have to see a situation where there is effective compliance and persistence. So a holistic approach is going to be critical for sustainable weight loss. That means best use of the stream of agents coming in, patient information and education, as well as doctor and education in that respect, and patient support. And the kind of policy issues that we think are critical for payers and governments to work through are questions around investment and return, both who do you spend money on and what time horizon for impact, and how can the savings be modelled out. The criticality of equitable access, both within wealthy countries, but also across the world, because the vast majority of obese people by 2035 will actually be in lower and middle income countries. And I also think that payers have to think about sustainability of competition. The new AOMs we have now are extremely good. The ones that are in the pipeline may be even better. And we have to create a situation where those also can make it to market and be used by the patients that need them. Thank you.
Thank you very much, Sarah, for a really interesting overview and, giving us the global perspective. And I think this is a really important area. And I hope that our audience are now willing to provide some comments, suggestions. So I will now open up the floor for discussion, some questions that may come in for all of our three presenters. So if we could have all three presenters just pop up on the screen. Lovely. Great. So I don't see any questions in the Q&A or in the chat functions. Oh, apologies. I do see one. So I think this question is for Sarah. So Kean Ryan has asked or has commented saying, I have some clients on Ozempic who have achieved weight loss rapidly. However, I suspect that they lost a lot of muscle mass also. Strength testing was markedly lower in these clients after their weight loss. This began to affect their quality of life. I feel this is being missed as prescribers are only looking at weight loss and tracking that. What are your thoughts on the rapid muscle mass loss with these drugs? Sarah, would you like to answer this question?
I'd be happy to. So it is widely discussed that the challenge with the existing new AOMs is that when there is weight loss, it is both fat loss and muscle mass loss. And particularly if you're talking about elderly, older patients, patients with mobility problems, patients who have not been exercising, then that's really a very serious issue. So it definitely should be tracked. This is one of the reasons why it's important that we look at that pipeline, because it's definitely been recognised that muscle preservation is important. And what we see in the pipeline is that there's several different types of mechanism of action that have been specifically developed to try and address that issue. So if you look in the pipeline in the earlier phases, you'll see myostatin analogues, preserving agents, and it's possible that those could be used in combination with GLP-1s. And there's other non-GLP-1 approaches being developed that also would have potentially a greater possibility of preserving muscle. So I'd say it is an issue. It is a recognised issue. It is an issue that a number of companies are developing newer agents again. And I think that's just a feature of the fact that we're at the very start of the development of the therapeutic armamentarium for obesity treatment. And these are not the best agents. There will be better agents that will come into the market over the coming decade.
Of course, yeah. I mean, that is something that will need to be considered in more detail, I suppose, moving forward. And it's definitely an important point that you've highlighted there, Sarah. So thank you very much for your response. I have a more general question, either for both Anagha or for Joe, in relation to, are any of you aware of any good utility sources specific for BMI reduction? So, for example, in both of your presentations, you mentioned changes in BMI as one of your outcomes. And I'm wondering, are you aware of good sources, maybe if you're happy to remind our audience where you obtain these measures in your models, please feel free. So Anagha, perhaps you would like to go first?
Yes, of course. So I think in both our studies, we incorporated utilities. So I was specifically looking at that, well, from age 5 to 17 within the modelling, and that was derived from a published systematic review by Vicky Brown and colleagues. And that was the one where it was they didn't find a whole lot of studies out there in that at that point in time, but when they brought the results together in a meta-analysis, there was a smaller utility value for higher weight groups. So I can respond directly with the reference for that study if that's helpful. I also, as part of my PhD, conducted another study using observational, like a large, that same study that Joe was talking about, the LSAT study, used the values from that. So they had collected utility in children using a adolescent utility tool. So I've calculated some specific age specific and sex specific utility values based on that. So I can also give you the reference to that if that's helpful. And I'll let Joe respond because I know he's got other utility values he used.
Thanks, Anagha. Yeah, I think, Romy, it just really depends on what you're trying to evaluate. So if you're evaluating, say, an intervention that's been conducted in a trial, the best source for utility values is ideally if you can get that from patients that are participating in the trial, in terms if there's a change in utility with the change of BMI as a result of the intervention. However, that's not always feasible, and in those cases, or in our case where we didn't have a trial intervention, and also when we're modelling into the future, the best source is from systematic reviews and meta-analyses, and that's in line with ISPOR's best modelling practices. So as Anagha mentioned, there has been a systematic review meta-analyses for overweight and obesity in childhood. And as part of my PhD, I actually did one for adults. However, I limited my systematic review just to Australia because there is difference between countries, and it really depends on what instruments you're using to measure utility. But yeah, I was still able, I think I had about 10 to 13 studies, and I was able to put those in a meta-analyses. And we did find that there was utility decrements with increasing weight status. And what I was further able to do was actually demonstrate that by obesity classes. And as Sarah, mentioned, most, the really poor outcomes you see with obesity are those in that real severe obesity category. So to be able to differentiate those health outcomes for those with severe obesity versus obesity alone is very important.
Great, thank you very much, Joe. And we have another question for Anagha. So one of our colleagues from the Obesity Cobweb Network, EMEA, she was wondering if you, Anagha, could describe the sleep intervention that you looked at evaluating in your presentation, and how maybe provide us a brief summary on how this intervention was conducted and carried out.
Sure. It's an answer I should know more detail about than I do, but I will do my best. The trialists, Rachel Taylor and Barry Taylor, who are the lead trialists on this study, know about this in a lot more detail than me. But essentially, so that for that particular intervention, there were two parts to it. There was that standard one that was given to all families, and then there was the optional component. Overall, it was mainly a behavioral advice intervention, and it's sleep. It's about targeting the sleep behaviors for the child, in case that wasn't clear. And so I think the first part of the intervention was given to the families antenatally, so before the birth of the child. And then there was a part when the child was 3 weeks of age, and I think there were nurses that came to the families, and they gave more directed advice at that point. Then there was those more optional components. Again, they were, I think a lot of families could just say no at that point, or they could ask for that extra bit of help. And so that had 4 different levels. Some of it was quite simple advice, could be around settling techniques. And then there was sort of more structured, high intensity interventions, which is more around those, I think it was called a modified, I've already forgotten what it was called, but I think it's about sort of increasing the amount of crying time allowed until coming to settle the child. So yeah, so quite simple advice, ranging up into more intensive interventions.
Great, thank you very much. And I hope this answers and clarifies the intervention a little bit more. I guess there's another follow-up question to Joe. So Amelia says, I didn't really understand to whom the digital intervention was targeted. It looked like it was hypothesized that the whole BMI curve shifted to the left, which may indicate that adolescents, regardless of weight status, were included. I imagine that preventative and treating digital interventions for adolescents have different approaches. Would you like to comment on that, Joe?
Yeah, absolutely. Thanks, Amelia. Yeah, you're correct. So everyone in our population, our intervention cohort, received the intervention. But just note, our population was only adolescents with overweight obesity. So we didn't have any adolescents with healthy weight in that cohort. We just used those that had overweight and obesity to start with. And the source of that intervention effect was from a systematic review and meta-analysis of 5 studies in a subgroup of adolescents with overweight and obesity only. So we're very narrow in that group. And that was from, 5 studies, and that was a range of interventions. So there was a text messaging intervention, like an app, telehealth intervention. There's a range. So our academic paper wasn't it wasn't for a specific intervention. It was just to explore the effects of, digital health interventions in general. Could they be cost effective by, using evidence from the literature and then modeling that over the lifetime trajectory. So hopefully that answers your question. And you're totally right. Yeah, preventing and treating are different things. I think in some way, I guess we're preventing future chronic disease by early intervening in adolescent overweight and obesity early. But then there's also argument that there's preventive interventions out there that are, helping adolescents develop good habits so they don't develop excess weight. Yeah.
Great, thank you very much, Joe. And I don't see any more questions that have come into the Q&A. So while people gather their thoughts, I have a question for you, Sarah. And I'm wondering, so based on your presentation, you've presented some initial evidence, but I'm wondering, how will we develop further evidence to understand the kind of wider impacts of obesity agents in other areas of health beyond obesity, looking at other chronic conditions, for example? And I know you touched on that slightly, but would you be willing to comment and perhaps give some suggestions on that?
Sure. So I think this is going to be absolutely critical. We saw that the companies behind the agents are doing very large-scale clinical trials. I mean, as I mentioned, Selectis was 17,000 patients. So there is a lot of investment by the companies behind the agents. But of course, it's not always the case that trial populations are completely reflective of the demographics of obesity in a country. Sometimes they're reasonably reflective, sometimes they aren't necessarily. So that's why I think that health systems, particularly in Europe, will probably, like NHS England has, be very interested in requiring real-world studies at the same time as these outcome studies are being done. I think it's not either or, they're doing different things. A real world study like Surmount Real, which is going to be backed by Lilly, the company behind tirzepatide, is going to, we expect, look at a wider collection of outcomes, which could include, of course, the impact of weight loss on a person's integration back into society, their exercise levels. There has been some discussion, although it's been controversial, about whether understanding if weight loss helps people back into employment or not should be part of the expectations there. But this is, I think, doing what is necessary, which is to reflect the fact that obesity is something that affects the whole of a person's life, not just their health. And therefore, if you want to understand the true impact of obesity agents, you've got to look at a very broad range of real-world parameters as well. And that's pretty complex in terms of measurement, and that will be one of the challenges. I think we're helped by digital technologies more these days because platforms like Apple Watch can help us understand a wide range of metrics in that respect. As I said before, we're at the start of the journey of using obesity agents. Probably less than 1% of the world's obese people have even had access to these agents. And that's why it's the next 10 years plus that are going to be critical in understanding the value of AOMs to health and healthcare systems.
Thank you very much, Sarah. And I suppose just moving on to, the kind of the model that both Anagha and Joseph, that both of you presented on, and, you did highlight that there were quite a few similarities. We have a question in terms of the model in particular. Alina wants to know, is it correct that there are different versions of the model? And what are the differences between these models, if there are different versions? And are there any other differences that these models account for, except besides the time horizon and the socioeconomic position aspect? So I'll open it up to either of you to comment on that. Thanks.
Yeah. Thanks, Lena. Yeah, so I guess we better acknowledge Professor Alison Hayes and Associate Professor Tom Long, who were really the developers of these modelling methods, and then Anagha and I have further expanded the modelling. So yeah, Tom and Alison, they first developed adult model, so that was the kind of from 20 years onward, that part of my model, and they use National Health Survey data in Australia over 20 years and across synthetic cohort approach to estimate a BMI trajectories from 20 years of age to lifetime to death and to 100 years. And then they also use the LSAC longitudinal study of Australian children data, and that covers children from 4 years of age, currently up to, I think, 19 now. And they first developed that modelling method from 4 to 15 years. And so things that, I guess the inputs that drive the modelling are an individual's age, sex, and BMI, and that's what informs those annual BMI equations that guide the trajectory. And my contributions to the modelling was that at the time of the childhood, the early, the 4 to 15-year-old childhood model, that was as far as the longitudinal study had been released. So there's data from that study every 2 years. And when I came and did my PhD, there was an extra couple of waves, and that allowed me to extend the model from 15 years to 20 years and then blink that up to the adults. So then we can really model that lifetime approach. And I'll let Anagha take over because obviously she developed the socioeconomic part of the equations. Yeah.
That joining between the young groups and the older groups is just a massive development, because in a lot of our studies before Joe came to do his PhD, the criticism we constantly got was that, you know, we're not able to model out those long-term outcomes for interventions that are happening at such a young age. So that has been a major development. With my PhD, my main goal was to incorporate socioeconomic position into that model. And in the end, it wasn't exactly a direct adaptation of the existing EPOC model. Instead, we used similar methods, but we started developing modeling equations using the same source data, but not using the same modeling equations to begin with, if that makes any sense. So we use the same similar source data, but then we had that extra piece of information around socioeconomic position to then try and develop equations that matched high SEP and low SEP. And one of the things that came out of that is that that resulted in a bit of a difference between the original EPOC model and the EQ EPOC model, which is the one that incorporates SEP, is that the EQ EPOC model, we had to separate out weight status into just those two groups, so healthy weight and overweight and obesity, whereas the original one could separate it out into three, and that was just about getting the accuracy of the predictions appropriate, and we just couldn't get that for once we separated out by SEP group and our three overweight and obesity groups. But yeah, that's the main difference, and it is something that continues to be worked on. It's part of a large project.
Excellent. Thank you very much. So I would like to take this opportunity to thank all three of our speakers for contributing and for really giving us very insightful perspectives on, you know, both from Australia and at the global level as well. So thank you all. And we will be, so these webinars are run a few times a year, and we will be organizing more webinars in 2025. So this is officially the last webinar of 2024. So please keep an eye out for upcoming webinars. Just to remind you all, this webinar was recorded. It will be shared with you all through email. I have just popped up our Obesity Cobweb website where you can access our previous webinars, and you will be able to access the recording of this webinar also. If you would like to contact or get in touch, please feel free to email us or simply go to the website. If you want to find out or join our network, please send us through any of your queries and we'll be more than happy to get you involved. So without further ado, I will close this webinar and thank everyone again. Thank our presenters and all participants for joining. Thank you very much.